us for our action period call and safe sleep webinar today. In the interest of time, we'll go ahead and get started. I see some of y'all are already doing this, but go ahead and put your name and organization in the chat box and send to everyone. This does help us know who's here and keep up with our honor roll. Please also chat whoever's in the room with you so that they can get credit as well. Everyone's automatically muted, but you can always come off mute and ask a question or put your question in the chat box. We do have people monitoring the chat box throughout the call, so we will get to your question. We will also have a Q&A at the end. Slides and the recording will be available on our website and then in the follow-up email next week. Okay, our agenda today, we're going to go over a few updates, and then we're going to turn it over to Dr. Moon to do our external speaker, our webinar, and then we will have some time for Q&A hopefully at the end, but if not, we can always get your questions via email and send them to Dr. Moon as well. And then if we have time, we'll go over some quick next steps for our teams. A few updates before we get started. Just data reminders, your June data and quarterly for April, May, and June, so quarter two. Data for Project Cribs is due July 10th into Simple QI. Please let me know if you need help with that and I will get that sorted. Also for our neonatal hypothermia project, our last quarter of sustainability, so April, May, and June, is due at the end of July, so July 31st. Those surveys are still coming from RedCap. You should have received your last one earlier this month, but if not, let me know. I'll get it sent your way. Also, just a reminder, we'll have our honor roll, our first honor roll for the Safe Sleep Project coming out next month. So your attendance in this call does go towards that, and looking forward to announcing that. Also wanted to remind you guys, I sent out a survey to our team leads and data champions. This is just a survey, quick 2 questions about our interventions. What have you been able to complete since starting the active phase of this project? So we are 6 months in, just kind of wanted to get a pulse check on what you guys have been able to complete. So if you are a team lead or a data champion, if you don't mind, scanning this QR code and getting the survey done by the end of the month. Naomi's also putting it in the chat if you don't have your phone with you. Much, much appreciated. Okay, I will turn it over to Dr. Moon. I'll do a quick introduction. So Dr. Moon is the Harrison Distinguished Professor of Pediatrics at UVA Health Children's. Before joining UVA in 2015, Dr. Moon worked for 2 decades as a pediatrician and in various leadership roles at Children's National Medical Center in Washington, D.C. As an internationally recognized researcher in the field of sudden unexpected infant death, her research interests include understanding parent decision-making in infant care and evaluating messaging strategies that can positively impact these decisions. In addition to her clinical and research duties, Dr. Moon is the chair of the American Academy of Pediatric Task Force on Sudden Infant Death Syndrome and an associate editor of the AAP Journal Pediatrics. Thank you so much for joining us, Dr. Moon. Excited to hear from you.
Thank you for having me. I hope that you can see my slides. If you can't, then just yell. I'm going to be going quickly through this because I was asked to talk about 2 different topics, and so it's actually 2 hours of stuff that I'm cramming into 1 hour. So I'm hoping that we'll have time for questions, but if not, as Caitlin said, then I'm happy to respond by email after the fact. So let's go ahead and plunge in. We're going to mainly be talking about the science of safe infant sleep and how we get from the data to the guidelines and what kind of data there is for the guidelines. I don't have anything to disclose, and I hope that by the end of the session, you'll be able to articulate what the goals of safe sleep safe infant sleep guidelines are, understand some of the epidemiologic and the biomechanical evidence base underlying the newest sleep positions, and then finally be able to create messages that don't reinforce harmful social norms, and we'll talk about that. So just to begin, so we're all on the same page, we're going to go over some definitions. So SUID is sudden and unexpected infant death. Sometimes it's called SUDI, sudden and unexpected death in infancy, and this is exactly what it sounds like. It's when an infant, so meaning somebody who hasn't had their first birthday yet, dies suddenly and unexpectedly. So sudden unexpected infant death is a huge bucket, and the vast majority of them, of these deaths, occur in a sleep environment or uh, when the baby is asleep. And so we call them sleep-related deaths. About a quarter of them are determined to be accidental suffocation or strangulation deaths, and then the rest of them are coded as either SIDS deaths or ill-defined or cause unknown. When we look at trends over the last 20, 30 years, you can see, so we'll look at the orange line first. This is this line for SIDS, and you can see there's been a steady decline there, except for the last few years. But then at the same time, the deaths from accidental suffocation and strangulation and unknown cause have gradually gone up, such that after a steady decline in the late 1990s, really since about 1998, there has been no change when you look at the rates of all three of these combined. When you look at trends by race and ethnicity, let me orient you here. So on the right-hand side is non-Hispanic Asian, Hispanic, then non-Hispanic white, non-Hispanic more than one race, non-Hispanic Native Hawaiian or other Pacific Islander, non-Hispanic Black, and then non-Hispanic American Indian Alaska Native. So you can see that there are huge disparities and that those have been fairly persistent over time. When we think about SIDS, we think about asphyxia, which means you're not getting enough oxygen. And we know that the vast majority of these deaths are respiratory deaths. That's it's when a baby stops breathing. Um, and there are a lot of reasons why this may happen. And the main thing that I want you to know is that many of the risk factors are associated with potentially asphyxiating environments. So these are environments where the baby can't get enough oxygen. So this would be sleeping on the stomach or on the side, sleeping with soft bedding, pillows, bumper pads, etc., bed sharing. There are some of these situations that would cause death in any baby. So let's say that the baby had fallen off the bed and had slid between the mattress and the wall and got stuck there and had the chest compressed and so they couldn't breathe. And that would cause death in almost any baby. But there are a lot of situations where only a few babies die and not others. And so why is that? So we think about the triple risk model, which many of you have heard about. And this is an interplay between arousal, the baby waking up, and asphyxia, the baby not getting enough oxygen. So you have a vulnerable baby, and the vulnerable baby is vulnerable because there is some kind of dysfunction in their brainstem. And this may be because they have some a different gene makeup, or they've been exposed to prenatal alcohol or tobacco or drugs, which can impact on them. And basically, what happens is that that baby has a problem with arousal, that there's an arousal defect. And then this baby goes through a critical developmental period. And we know that the highest risk for these babies is between 1 and 4 months of age. And then when you have this vulnerable baby that's going through this critical developmental period, and then you stress them by putting them on their side or stomach, or by bed sharing, or by using soft bedding, then that creates an asphyxiating environment. And so you have this combination of an asphyxiating environment and the baby's not getting oxygen, and then they can't wake up to save themselves because of this arousal defect. The other way to look at this is that it's an interplay between genetics and environment, and we see this in a lot of diseases. I like to talk about adult cardiac disease, cardiovascular disease. So if you have somebody who has a heart attack, why is that? And a lot of people, it may be, or for very few people, it may be all genetic. So over here on the very far left, so they do everything right, but this is the marathon runner that you hear about in the news that drops dead of a heart attack. They do everything right, but somehow the genetics is too much against them. And then on the other extreme, it's all lifestyle and environment. So these are the people that don't take their medications, don't watch what they eat, don't exercise. They're doing everything that we would consider wrong. And so then when they drop dead of a heart attack, nobody is surprised. The vast majority, truthfully, are somewhere in the middle where there's some genetics and some lifestyle and environment. And the same is true for babies who die suddenly and unexpectedly. There's some combination of the environment and then genetics. So there's a lot of work that's being done on the brainstem, and a lot of attention has been focused on serotonin. And serotonin does a lot of things in the brainstem. So it helps to control breathing, respiration, upper airway control, temperature control, heart rate, blood pressure, and sleep and arousal. So this is serotonin receptor binding in two different scans. The left scan is a baby who died of SIDS, and the right scan is a baby who died of something else. And you can see that there's a big difference in the greenish yellow lighting. That's the serotonin receptor binding. And so the baby who died of SIDS has almost no serotonin receptor binding, whereas the other baby has a lot. And so that's an example of how this could be genetic. So what happens when a baby doesn't wake up is that, let's say that they are here and they're lying on their stomach and actually lying face down, they start to have problems getting air, and they're not getting enough blood going to their brain. And so one of two things can happen. They will wake up a little bit and then turn or lift their head, in which case this whole sequence will be aborted and they'll be fine. Or they don't wake up and then they just continue on until they die. And so this is what happens when the baby doesn't wake up. Risk factors are risk factors because of one of two reasons. One, they make it more difficult for the baby to wake up. So sleeping on the stomach and side, everybody wants to do that because they think that babies are going to sleep longer, they're going to sleep more deeply, they're not going to wake up. But that's the problem. They sleep more deeply, they don't wake up. And then so if they get into trouble, they're not going to wake up. We know that smoke exposure, both prenatally and then after birth, decreases your arousal. And then we also know that sleeping on the back, breastfeeding, room sharing without bed sharing, and pacifier use all increase your arousability. The other reason that risk factors are because they create potentially asphyxiating environments. So soft bedding, bed sharing, sleeping on the stomach, or sleeping on the side. These are the 2022 AAP Safe Sleep recommendations. These all impact arousal, and these all can decrease the risk of asphyxiating environments. So the goals of the safe sleep and guidelines are to increase arousability, make it easier for that baby to wake up, and to decrease those asphyxiating environments. So now I'm going to talk about a little bit about the safe sleep guidelines themselves. So there are some that we call oldies but goodies. So babies should be placed for sleep on their back for every sleep by every caretaker in a crib, a bassinet, or a portable crib that meets federal safety standards. And there should be nothing in the sleep space but the baby. They should be in a smoke and nicotine-free environment, both before and after delivery. There should be no alcohol, drugs before and after delivery, and then offer a pacifier at sleep time. These are some odds ratios, which means the increased risk with some sleep practices, just so that you can see. So if you sleep on your stomach, it's anywhere from 2 to 13 times the risk. If you're placed on the side and then you roll over onto your stomach, then it's almost 9 times the risk. So really, if being on the side is actually no safer than being on the stomach because of the fact that you often will roll to your stomach. Bed sharing overall, and we'll talk about this, is almost 3 times the risk. And then there's certain situations of bed sharing that increase the risk even more. So sleeping on the couch or armchair is awful, 22 to 67 times the risk. Bed sharing plus alcohol or drug use is 53 times the risk. Bed sharing with if the mother is a smoker, almost 18 times the risk, and on and on and on. If there is tobacco exposure prenatally, for every cigarette that the mother smokes per day, there's a double the risk of the baby dying. And then you can see some of the other ones as well. There are also some protective factors. So if you use a pacifier, then you have a 29% less risk of dying. Any breastfeeding less than 2 months of age is not protective, but any breastfeeding starting at 2 months of age is protective. And this is a 40% protection, and then at 4 to 6 months is a 60% protection, and on and on. And so the protection increases the more and the longer you breastfeed. Okay, so I want to show you this video to remind you that babies will not choke when they're on their backs. This is a big misconception, and this is a big barrier for families to put their babies on their back. So let me just show you this video. Unfortunately, I can't provide this video for people because we're still using this in our research studies, but you can get something similar to this on the Cribs for Kids website. Today, babies won't choke when they're on their backs. Based on recent studies, today's baby recommends that babies always be placed on their backs when sleeping. Babies who sleep on their stomachs are more likely to die from SIDS or to suffocate. Babies who sleep on their sides are more likely to roll onto their stomach. Someone may tell you that a baby will choke if he spits up while he's on his back, but that's not true. First of all, humans have a gag reflex that keeps us from choking. If you hear your baby gagging, it doesn't mean that he's choking. It means that he's protecting himself from choking. In addition, our bodies are designed so that it is harder to breathe food into the lungs while we're lying on our backs than when we are lying on our stomachs. Here is a diagram of a baby who is sleeping on the stomach. You'll see that the esophagus, or the food pipe, is above the trachea, or windpipe. If this baby spits up, it is easy for the food to go down into the lungs. If your baby is on the back, the food has to go up against gravity to go down the windpipe and cause choking. So sleeping on the back will protect your baby from SIDS, suffocation, and choking. Today, babies won't choke when they're on their backs. Okay. Okay, so now I'm going to move to product safety and talk a little bit about the Product Safety Commissioner, the CPSC. The CPSC works to reduce the risk of injuries and deaths from consumer products by doing three things. They develop voluntary standards with industry, then they issue and enforce mandatory standards, and then they ban consumer products if no standard would adequately protect the public. It is a reactive agency. It is not proactive. So it can't do anything until something bad happens or there are complaints about a product. But it does work to improve products after they're on the market if there are problems. When the CPSC recalls products or reports product problems, it only works if the manufacturer agrees. Because if the manufacturer doesn't agree to recall the product, then it's basically just a warning to consumers, but they can't really do anything. Their hands are tied. So there are a lot of holes in this process, and I'm going to give you an example. So there are currently mandatory safety standards for a few products: cribs, bassinets, play yards, bedside sleepers. And then at the end of the Biden administration, we were able to get mandatory safety standards for nursing pillows and infant support pillows. But we haven't seen anything in terms of mandatory safety standards since then. There are also legislative bans. The Safe Sleep for Babies Act in 2021 makes it illegal to sell, distribute, or manufacture padded crib bumpers and incline sleepers, anything over a 10-degree incline for infants. And this happened because of the Swiss cheese, all the holes in trying to get Fisher-Price, basically, to take the incline sleepers off the market, the rock and play. And so let me show you a little bit about that. So as you know, Fisher-Price is well-respected manufacturer of infant and child products. In 2009, the rock and plays came on the market. So there are 4.7 million sold. They were developed without any clinical research supporting safety. And the company's own safety commission warned about safety concerns 3 times in 2008, 2009, but the company did not recall the product. Okay. Beginning in 2012, there were reports of several babies who died after rolling onto their stomachs and suffocating. So the AAP pushed for a recall. Fisher-Price responded by just putting a warning label that the product should not be used after the babies could roll. 2015, ASTM, they released a voluntary standard. The Fisher-Price staff were key members of the subcommittee that created that standard. So it's a little bit like the fox guarding the hen house. Then in 2019, Consumer Reports reported 32 deaths and pushed for a recall. And they only were able to do that because they asked for data from the CPSC, and the CPSC sent them data that they forgot to redact. And so then Consumer Reports sent something out. And so finally, Fisher-Price recalled the product right before the Consumer Report was published. But even since then, there have been at least another 70 deaths that have occurred. So there's several holes. One, it was developed without any clinical research. The company did not recall the product, even though their own safety commission warned against safety concerns. They didn't recall it after the reports of several babies. Then they were key committees, members of the subcommittee. So there are lots of holes in the system. So we say 10 degrees, and I'll talk about that in a minute. But how much is 10 degrees? This is 10 degrees. So this is a typical car seat. A typical car seat puts the baby at 45 degrees. Okay. And so we don't want the baby sleeping in a car seat unless they're actively traveling. So why no more than 10 degrees? If the baby is at more than a 10-degree angle, it is harder for them to keep their airway straight. Their head is big and heavy. Their neck muscles are not very well developed. So they have to use more neck, trunk, and stomach muscles to keep their airway straight. They're really, really struggling to do this if they're at an incline. So they are more than twice as likely to have dangerous dips in their oxygen level. So you have to remember that an infant airway is 4 millimeters in diameter. This is smaller than a typical drinking straw. A drinking straw like this is 6 millimeters in diameter. So you can imagine if the baby's head is forward or to the side, that you're going to kink that airway, and that's going to be a problem in terms of the baby getting oxygen. So when you think about product safety, there are a couple of things that you want to keep in mind. Babies need to be able to wake up easily. They need to be able to feed every 2 to 4 hours, and we know that the ability to wake up is protective. Second, we need to keep the airway clear, starting from the nose and mouth all the way down to the lungs. Anything soft or padded can block the nose and mouth. And think about what could happen if the baby's not on their back, if they roll over onto their side or roll over onto their stomach. They can roll into bedding, they can roll into bumper pads, all of these things. You have to remember that babies are vulnerable. Not only do they have big heads and not well-developed neck muscles, but they also don't have a lot of strength to push something away or push themselves away. So you have to think about that. And then finally, again, you want to think about the baby's airway as being like a drinking straw and that it needs to be kept straight. Finally, you want to think about human factors because humans are unpredictable and they are not always rational. They don't do things that make sense all the time. So you have to assume that, and you have to think of all possible scenarios when you're thinking about infant safety. We think that the best place, and the evidence shows that the best place for the baby to sleep, therefore, is in a flat, meaning a horizontal, not inclined, firm, which means hard, surface that meets safety standards. So the four that I talked about that have safety standards are crib, bassinet, play yard, and a bedside co-sleeper. Babies should be on their back even when they have reflux. Number one, there's no evidence that being supine, being on their back on an incline helps. And there was one study that looked at 30 babies who put them prone on a bed at 40 degrees, and it did work for reflux, but 27% didn't tolerate the positioning. And this is an example of a wedge that we don't want to use. And again, remember that when babies are at more than a 10-degree incline, it is actually harder for them to breathe. These wedges are problematic because, again, when they're at an incline, they can turn to side or prone more easily. Babies slide off, or they turn when they're on them and they have suffocated. And so wedges now have to meet safety standards for infant support pillows. If babies should have a cold, they need to be on their back, flat on their back. Okay. Like I said, the biomechanical data shows that it's harder for babies to maintain their oxygen levels when they're at more than a 10-degree incline. So why would you put a baby who's already having trouble breathing, why would you put them at an incline? Because that makes it even harder for them. Okay, moving on to tummy time. We have become much more specific about how much tummy time because there's more evidence about this. So we want babies to start in tummy time beginning as soon as they get home from the hospital. And then you want to increase until they get to about 15 to 30 minutes total every day by the time that they're 7 weeks old. Okay, so just start little by little, but you want to start as soon as they go home. What I tell parents is that they can put the babies on their chest when they are awake at the beginning, and then once the baby's umbilical stump falls off, then they can go on a flat floor. So the reason why we are able to give more specific guidelines about this is because of studies that show that if you use as much tummy time, then you are less likely to develop head molding, plagiocephaly, and you're less likely to have problems with your gross motor milestones. Okay, moving on to sleep position. We recommend, and I think you all know this, that babies sleep in the parent's room, close to the parent's bed, on a separate surface designed for babies, ideally for the first 6 months. We never, ever, ever want babies to be on couches or armchairs. These are extremely dangerous. I told you it's 67 times the risk. They should never be used for infant sleep, either with or without another person, despite what Facebook says and Instagram says. So in terms of bed sharing, a lot of parents choose to routinely bed share for a lot of reasons, including it makes feeding easier, maybe cultural preferences. But look at the risk of this. So baseline increased risk of bed sharing in any circumstance is almost 3 times the risk. If the baby is younger than 4 months of age, even if the parents are non-smoking, it's 3 to 10 times the risk. And then if they're on a sofa or armchairs, up to 67 times the risk. So the AAP is unable to recommend bed sharing. We do believe that having the baby close to the bedside in a crib or bassinet allows parents to feed, comfort, and respond to their baby. So we've had parents that we talked to this about, and one of the mothers said, I don't understand why this is such a big deal. Because when the baby is in the bassinet next to me, really, our heads are only 12 inches apart. And then I can see her, she can see me. I can, wave at her, she can see me. It's not a big deal. A lot of people ask about harm reduction as a public health approach. There are pros and cons to this. On the pro side, it keeps babies as safe as possible in a potentially dangerous situation. The people that advocate for harm reduction says they say it doesn't mean that you condone it, but it provides a more neutral approach so you don't seem judgmental. And then some other countries, specifically the United Kingdom, have taken this approach. Disadvantages, it may increase the undesirable behavior because people believe that they can do it safely. If nothing bad happens, then they think that they're doing it safely. Um, if you take an approach that and you say, well, let's take a good, better, best approach, this implies that good is actually safe. But when you look at all of these bed sharing situations, the risk is 3 times higher. And for high risk situations, the risk is 10 times higher. So I would argue that we can't really say good, better, best. And I would actually argue, does it make sense to do this? NPR put out this graphic a few years ago, and what they said was that the chance of a high-risk baby dying from SIDS while sleeping in the parent's bed was 1 in 150, 10 times more than the high-risk baby dying of SIDS while sleeping in a crib in the parent's room. And then they made the point that if your baby is low risk and you're bed sharing, that it is about the risk of being hit by lightning in a lifetime. So everybody says, so it's really not that risky. So my question to you is, if you are on a golf course or in a swimming pool and you hear thunder, what do? You get out, right? You get off the golf course or you get out of the pool because you're worried that you're going to get hit by lightning. So why is it that people feel that that is important to do? Whereas bed sharing, which is as risky as that, people do not feel compelled to make that change, and they're okay with that. So there is definitely a disconnect in terms of how we think about risk and what kind of risk we're willing to live with. So there are a couple of reasons why the AAP doesn't recommend the harm reduction approach. Number one, it has not decreased suicide rates in the UK, and rates of bed sharing deaths may be increasing there. We don't really know how to exactly make bed sharing safe. Parents may not be forthcoming about the specific situations that may be high risk. So they may not tell you that they vape. They may not tell you that they drink alcohol, they drink wine with every dinner, or they have a beer. Um, it's also a problem with what is said versus what is heard. So if I tell a parent, well, you know what, we don't recommend that you bed share, but if you're going to do it, then you can do it if you do A, B, C, D, E. So then when the mother goes home and the grandmother says, so what did the doctor say about the bed sharing? Oh, the doctor said it was fine. Okay, so there can be a difference between what is said and what is heard. And then there's something that I call champagne effects. So you tell a parent that they are low risk because they're not smoking, they're not drinking, they're breastfeeding, all of these things. So they're low risk, and you counsel them that way. So then the next day, let's say that it's their anniversary, and they say, "Oh, let's have some champagne." So all of a sudden, they have become high risk, but they don't know that they don't recognize that they are high risk. And so they continue to do it to bed share because they assume that they are still low risk. So there are these day-to-day changes in the situation that change the risk as well. Finally, and not that you should do everything based on what the liability is, but the AAP is very concerned that if we tell parents that it's okay for them to bed share in specific situations, and they do that and the baby dies, that creates potential liability risk for the provider. So I know that this is a little bit like it's a very nuanced thing. So what we say in the AAP, we try not to give permission to people to give to bed share um, in an overall way, but we do recognize that a lot of parents fall asleep while they're feeding their babies, and that most of it is unplanned, and that when it is unplanned, it tends to happen on couches, sofas, and armchairs, which is the most dangerous situation, as I mentioned. So if you are concerned that you will fall asleep while feeding, we recommend that you do it in your bed rather than on a couch or sofa or an armchair because that will be safer. We recommend that you proactively remove the blankets and the pillows from the bed, and that when you or the baby is ready to go back to sleep, that you put the baby in their own space. But if you unintentionally fall asleep with the baby, then when you wake up, just return the baby into their own crib or bassinet. So that's kind of where we've landed as a compromise. And so I'm just going to leave you with that. Remember that there are factors that can increase the risk of bed sharing, less dangerous to most dangerous, and these are important things to let parents know. So again, these champagne effects. So if the parent is in an accident and then is given pain relievers, because they broke their arm, then all of a sudden they have become a very high risk situation for bed sharing. So there are these risk factors that are important for families to know about. Okay, so now I'm going to move away from the safe sleep guidelines and to talk about messaging and to talk about a little bit about safe social networks and social norms. So social networks, when I talk about social networks, I'm not talking about Facebook or TikTok. I'm talking about the people with whom you everyone has a group of people that we communicate with on a daily or weekly basis. So family, friends, peers. And we know that not just parental behaviors, but any behaviors are often not easily changed just when we educate, because these behaviors are often not entirely based on scientific information. And instead, they are highly reliant on non-factual information from the people around them. Social norms are the unwritten rules of any group. And those are the rules that define what is appropriate in terms of how you behave, what you value, and what your attitudes are. So there are two different types of norms. There are descriptive norms, which is your perception of what is normal or prevalent behavior. So when your teenager tells you that everybody does this, that is a descriptive norm. An injunctive norm is what you perceive to be acceptable. So you are more likely to do what you perceive to be normal and acceptable so that people don't judge you. And these social norms are highly, highly influenced by social networks. So how powerful are these norms? I think most people have been to a Disney property before. And as you get closer to any Disney property, all of a sudden you see people that are wearing things like this. And these hats with the ears and these shirts with mice on them. And these are clothes that these people probably would not be caught dead in unless they were on a Disney property. And Disney has done this amazing job of creating normative behavior, that this is normal, this is expected. And if you are not dressed this way, then other people will judge you. And it's very, very powerful because people will spend $70 on a shirt so that they will look like everybody else. So we did an analysis of social networks of mothers, of young mothers, and each of these little clusters is a social network. The gray circle in the middle or in that cluster is the mother. The white circles are people in their network that told them always to put the baby on the back. And the black dots are people in their network who didn't always say that. And these are a group of mothers who placed their babies on their backs last night. And then let's compare that to mothers who did not place their babies on the back last night. And you can see there's a lot more black there. So there are a lot more people in these networks that are telling these mothers that it's okay not to put the baby on the back. And in some of these little networks, everybody is black. Every single circle is black. So that means that everybody is telling the mother to not put the baby on their back. So it's very, very powerful. When mothers make decisions, or when any of us make any kind of decision, the way that we usually do it is the first thing you do is you seek advice from multiple sources. So you crowdsource, you ask everybody. And then you weigh what you get from everybody with your maternal instinct, what feels right to you, what feels right for your baby. If everybody agrees, then most of the time you're going to follow the advice. If not everybody agrees, then you have to weigh all the advice and then make a decision. And then even after you make a decision, you still have to go back to those people to get feedback and say, okay, I decided to breastfeed. And then everybody will tell you what they think again. Okay. So we do this 100 times a day. If you're going out tonight and you're trying to decide what to wear, you probably have people where you'll put on several outfits. You'll send pictures of them to your friends or to people in your social network and say, "What do you think I should wear?" And then people will tell you what they think, and then you make a decision based on that. And then even after you make the decision, then what do? You put on the outfit that you decided on and you send another picture and say, "This is what I decided. What do you think?" Right? Because you're trying to get reassurance and positive feedback. So we do this all of the time. So the networks and the norms are important because the people in the networks are often the first people the mother will ask. They're often the last people the mother will ask. And there are multiple points in that flow chart where they can influence behavior. And mothers don't want to be judged. So that is really important. So then how do we change these behaviors? So first of all, remember that the social norm is a perception. It's not necessarily reality. So there is this perception amongst high school students, and if you have a high school student at home, you may have heard this, that everybody drinks. And this is normal. Okay. But the reality is that very few high school students drink. And so high schools have now um, begun campaigns to encourage their students not to drink by changing what the perception is and giving them factual information. So 4 out of 5 Panthers do not drink alcohol. Join the crowd. Photo contests are very good at doing this. So when we had a safe to sleep campaign and the NICHD, and we had CDC Safe Sleep efforts, every October they would do a hashtag Safe Sleep Snap challenge, where they would invite people to send in photos of babies in safe sleep environments, and then they would post them on social media to enhance the perception that everybody is doing this. So I don't know how many of you have been to Petrified Forest, but they had a problem several years ago where people were taking the petrified wood out of the park. And so they decided that they would put up signs to try to get people to stop doing that. And a very clever sociologist decided to study what happened. So there are two different types of signs. One that said, "Your heritage is being vandalized every day by theft losses of petrified wood of 14 tons a year, mostly a small piece at a time." And then the other sign just said, "Please don't remove the petrified wood from the park in order to preserve the natural state of the petrified forest." So if you're near your chat, I want you to put in which one you think is more effective, the left or the right. And I'll give people like a couple of seconds to do that. So go ahead and put that in the chat. Okay, so I'm seeing a few right and then mainly left. Okay, great. Thank you. Okay, so this one, the one on the left, the one that most of you voted for, had almost 5 times increased theft. So let's look at this and say why. So when you look at this, what is this message that we're giving people? We're telling people it's happening every day by theft losses of petrified wood of 14 tons a year, mostly a small piece at a time. So what we're saying here is that everybody is doing it. Okay. And so when you see this, I don't know, when I see this, I think, oh, wow. maybe I should go ahead and take some now because it's all going to go away. So, so we have, so this has just, this language here increases the behavior that you don't want because it's telling you that everybody is doing this. And so it's okay for you to do this. Whereas if you just say don't do it, that's much more effective. So how do we need to think about how we talk to people? So this is what I hear a lot. And I've said this in the past before. I understand why you're putting your baby on her stomach, but even though your family and friends may tell you that this is what they're doing, it's not a good idea. So what have I told them? I've told them that everybody is doing this. Okay? So, if you want to take advantage of social norms, then you might want to phrase it this way. Wow, I'd be interested in knowing why your baby is sleeping on the stomach because most parents I work with are now sleeping their babies on the back. Which is true because 75% of parents are putting babies on the back. So you're not lying to them. So if you say, wow, and are really surprised, then people, number one, they don't get offended. And then they're a little surprised that you're surprised. It's like, what do you mean that everybody's doing this? I thought everybody did it this way, but you're telling me everybody's doing it that way? And so you correct that behavior. The other thing that you want to do, and I don't have time to show all the data behind this, but it's important, number one, to give people tips for success, how they can do this better. What are the little things that they can do? Give them ideas for what might work for them. The second thing is give them praise for when they do something right. And what is shown to be really effective is a smiley face. So give them a smiley face sticker. Give them or put a smiley face on their after visit summary because that recognizes that they're doing a good job and they are going to want to continue to do a good job to get that kind of recognition and acknowledgement. Okay, so in conclusion, this has been rapid fire for all of you. So baby on the back, on a flat, non-inclined, firm sleep surface with nothing but the baby. No tobacco, vaping, alcohol, marijuana, opioids, because that decreases the baby's arousal and it increases the risk of in bed sharing. Only use CPSC approved sleep devices. More tummy time is good. Discuss the risk of bed sharing depending on the family circumstances. And then think about how you can use social norms to help you sell the message of safe sleep because it is a message that we are trying to sell. We are selling this product of safe sleep. So give parents tips for how to succeed, give them positive feedback and encouragement, and then please use a smiley face at the end of the day. Okay, thank you very much. I know that was a lot for a short amount of time, but I hope that that was helpful for you all. Shut this and stop sharing.
Thank you, Dr. Moon. That was amazing. That was great information. If you guys have questions, you can put them in the chat or come off mute.
Thank you, Dr. Moon. That was awesome. And yeah, especially the messaging part, that was very, very enlightening.
Thank you. I'm glad that it was helpful.
I thought it was interesting that the UK's approach to harm reduction didn't decrease their numbers.
No, no, it's really a problem. I mean, I don't know if we have gotten to the point where we're not going to, if we've reached the kind of a ceiling effect or and it's gonna we're gonna need more in the way of genetic and those kind of advances. But one of the big issues is that people think that this is a problem that's gone away because they hear that SIDS, the rate of SIDS decreased with back to sleep. So a lot of people think this is a problem that's gone away, and it hasn't. And so I feel like we still need to work on changing those attitudes, changing those norms. Um, and um, and I think that that's going to be really important.
I have a comment in the chat about the video, how not likely that the baby will choke laying on the back. That is very helpful.
Yeah. So now that, everybody has their phones and stuff, you can, if you de they definitely have still diagrams of the airway that you can use when you're doing teaching, but you may be able to download a video from the CRISPR Kids site as well.
All right, we'll keep an eye in the chat for any questions. And like I said, I can connect you guys to Dr. Moon or forward her any questions that you may come up with later. And this recording will be saved on our website and sent out if I want to refer to it again. I will share the screen again.
Also, I just threw a link in the chat. It's a Qualtrics. So if you fill that out, you'll be eligible for your CEUs, just so we can get your name and your information for that. So make sure to complete that, but we'll also send that out in other ways too, so you have access to it after this.
Thanks, Naomi. Okay, just a few quick reminders before we close. We are entering our third PDSA cycle. For Project Cribs, we've already focused on staff education, hypothermia prevention, and temperature management. So now wanting to focus on screenings and pathways to referrals. Some places already have this fully in place, but if you're looking for something to tackle for your next PDSA cycle, this would be a great one to start looking into, just making sure we're asking parents if they have a safe sleep space for their kids when they go home. And then if they say no, having a line to connect them with one. So next steps for you guys, meeting with your teams as we close out PDSA cycle 2, deciding whether to adapt, adopt, or abandon your ideas, and then begin meeting with your teams and thinking about PDSA cycle number 3, which will go from July through September. And then don't forget to enter your data into Simple QI and chart your PDSA cycles. You guys are doing a great job in Simple QI of getting everything in there, so I really appreciate that. As always, our website, emails, contact information, our Instagram if you want to follow us. And then our next meeting will be July 22nd. All right, thank you guys so much for joining. We'll stay on if you have any questions. But yeah, that was a great presentation and thanks for joining. And we will follow up about the CEUs. Thanks, everybody.